Okay, hello. We're going to start up on lecture 10 with innate immunity. Now, this is something you've dealt with before in anatomy and physiology too. No problem. This should be a review and will help us to understand things a little bit better. Okay? Um, what you want to do is be aware of that the immune responses are basically classified by either being innate or adaptive. When I talk about an immune response, I'm talking about physiological processes that are coordinated by the immune system to eliminate foreign substances, basically antigens. Now, the antigens may be attached to something alive or not. Keep that in mind. The common features of to both branches are to recognize diverse pathogens, to eliminate the identified invaders, and to discriminate between self and foreign antigens. Self is very important. Now, I know that sounds kind of a silly way to say it, but the immune system is not supposed to attack its own tissues. That's where we get into the topic of autoimmunity or autoimmune disorders, because that's when the immune system starts to destroy its own tissue. We're going to talk about the innate immunity, also referred to as nonspecific immunity. This is an inborn and ancient protection that exists in one form or another in all eukaryotic organisms. It is the more rapid response to a pathogen invader, etc. Now, the difference from that with adaptive immunity, otherwise known as specific immunity or acquired immunity, is that this type of immunity is a newer response and it's only found in vertebrate animals. Okay, so that's really a clear difference here. Before you had all the eukaryotes, now you just have vertebrate animals. It requires 4 to a 7-day window to fully activate. That's why I mean that the innate is extremely important, because it is the virtually on-site attack. Whereas with adaptive, it takes 4 to 7 days to really rev up and get moving. Adaptive will recognize antigens from pathogens it previously encountered. Now, you're going to deal more with adaptive immunity in chapter 12 in a subsequent lecture. So don't worry about that right now. Focus in on this chapter. And we're going to talk about basically the first and second lines of defense. These fall under innate immunity. The third line of defense is really the adaptive, and we'll deal with that in a subsequent lecture. All right. The normal microbiota helps basically prime or shape the immune responses and help maintain the immune protection. This is interesting because it also brings us to a concept called the hygiene hypothesis. And it proposes that decreasing diversity and levels of microbes in the normal microbiota will negatively impact the immune responses. That's where we've come to start seeing that it's almost as if you've heard this probably, too little dirt. We're all little kids and we all have a little bit of dirt. Well, if we have too little dirt exposure, dirt can be, actual soil. It can be raised in a farm versus raised in an urban setting. No animals around, no nothing. But too little dirt as a youth affects our subsequent sensitivity to allergens later in life. And this hygiene hypothesis basically directs us to help us to understand that what were, or presently what are allergens, may have basically been things that we would have grown tolerant to if we were very young. Also, some microbiota enhance our innate immune function. For example, I previously mentioned about this. The vaginal pH is kept low by the lactobacilli. These are acid-producing bacteria. They prevent infections of other organisms. If you use antibiotics that kill off the lactobacilli, the vagina is left open to subsequent opportunistic infections by Candida albicans. That's where some women have the problem of yeast infections. So as we look at this, we're going to have the 3 lines of immune defense in our discussion today. 2 of the 3, I should say. The innate barrier defenses, and the innate cellular and molecular defenses. The adaptive defenses will be in the next follow-up chapter. This is a nice little table. I like it because it gives you a clear representation of the differences and similarities, okay, between innate and adaptive immunity. Notice again I mentioned the response time. Innate immunity tools are immediate in response. Adaptive take 4 to 7 days to get moving. Organisms that have it, it's basically innate, is present in all eukaryotes. Adaptive is only found in vertebrates. Both innate and adaptive distinguish self from foreign antigens, and therefore, basically, you're not supposed to have autoimmune reactions. They will kill invaders. They both are effective against diverse threats. They both tailor their response to specific antigens? No. That's where the innate immunity tools fail. Adaptive do tailor the response, meaning, in other words, modulate it. Okay, battle's over, end this. Now, the other problem is that innate will not remember the antigen. It will not amplify its response upon later exposure. That's where adaptive does, and that's where we get into this point about also vaccines. After the first, second booster, etc., you're going to to teach the immune system so that it will subsequently react even further and stronger against subsequent exposures of the same antigen. So let's talk about first-line defenses. These aim to prevent pathogen entry. There are several subcategories. One of them is mechanical barrier. Hey, physical actions to flush, rinse, or trap microbes. That includes earwax, mucus, saliva, tears. We have the concept of the mucociliary escalator. This is the process where microbes are trapped in the mucus and they're swept out and basically gone by the ciliary actions of the trachea and the nose. So basically, when you sit there and you say to yourself, why do I have mucus that's in the throat and I have this thin layer that goes all the way down in the trachea? Because it acts almost like flypaper to capture antigens, bacteria, viral particles, etc. And the cilia underneath from the pseudostratified ciliary epithelium will sweep it up and it will either be swallowed or spit out. And okay, that makes a lot of sense. That's a mechanical barrier. By the way, when we talk about chemical barriers, these are molecules that directly attack microbes or generate an environment that limits their survival. These include lysosome, which is present in tears, saliva, mucus, breast milk. Basically, this is an enzyme that really breaks down bacterial cell walls. A couple of these other chemical barriers are remarkable. We take them for granted. The stomach acid, for example, or the urine. The low pH protects the urinary tract. Antimicrobial peptides, otherwise known as AMPs. These are proteins that will destroy a wide variety of mucuses and parasites and bacteria and fungi. They're found throughout areas like the skin, etc. You're going to see this also present in some of the secretions, mucus, milk, tears, saliva, earwax. One form of them are referred to as defensins. They actually destroy bacterial cell membranes by punching holes in the cell membranes. And then, of course, we have what we call the physical barrier. This is the skin and the GI tract. Remember, these are epithelial cells. They make up the skin. You have the keratinized ones. They block the entry of many microbes. Okay, keratin protein protects the skin, and you also have a lipid-rich layer of cells that basically prevent water loss and pathogen invasion. Quick, think about this. When someone has third-degree burns, what is, after the first 24 hours, the biggest threat for the survival of that individual with third-degree burns? Of course, infection. Because once you have burned away right down both the epidermis and the dermis, now you're exposed to the potential of infection. and not a little bit. For as big as that area is that's been destroyed, that whole area will be now subject to possibility of infection. Okay, something to think about. And here you see this nice diagram that breaks it all down, the mechanical, the chemical, the physical, etc. Keep in mind there's a lot of things we take advantage of. For example, stomach acid. This limits a lot of the pathogens. A lot of the pathogens are destroyed by the acidity of the stomach. You will only see unique organisms like Helicobacter pylori, and how that survives in the stomach is basically by converting urea back into ammonium ions to basically create sort of a mantle or protective covering that will neutralize the acidity around it. Okay. If you had someone who was consuming a great amount of either antacids or bicarbonate and just going to town with it, they're reducing the stomach pH, and thereby they're reducing the protectiveness of this chemical barrier against other subsequent infections. Here we have the AMP, which will do several things. One, it will stimulate leukocytes. Now, leukocytes will modulate inflammation, and they will clear pathogens by phagocytosis. AMPs will also directly target pathogens. They will act to target the intracellular components or processes, as well as disrupt the plasma membrane or cell wall. Now, as we move through this, we're going to start getting into the second line defenses and the lymphatic system. We've already covered the lymphatic system to a degree in AMP2, but we have to cover it again. One of the things to keep in mind is that second line defenses will kick in when the first line defenses have basically been breached. So in other words, once the infection has passed through the skin, once it has passed into the GI tract, now into the gastrointestinal walls, etc., you're going to have assorted molecular factors, leukocytes, revved up. Now, the lymphatic system collects, circulates, and filters body fluids. You know at the capillary level that basically we have fluid that goes out of the capillaries and into the interstitial fluid, but may also be recollected back into the capillary, but not all of it is. Remember that plasma is a liquid portion of the blood, and we have the interstitial fluid, otherwise known as extracellular fluid. This is going to be rich in proteins and leukocytes, but not all this fluid is recalled back. Now, it's either picked up by the lymphatic system, or in the case of, let's say, tissue damage, you will have edema, which is tissue swelling, because of the buildup of the fluid there. Now, in lymph, the fluid is recovered from the tissue and then transported via the lymphatic system. Eventually, the lymph gets filtered and is transported back into the bloodstream. Now, in that process of going through things like lymph nodes and lymph vessels and such, some pathogens may get transported, and then they may be attacked by various types of blood cells, such as the lymphocytes, leukocytes, etc. That's great, but some of that is going to be we're going to be dealing with also with the adaptive system. And here you see a diagram here. One, plasma exits the capillaries. Yep, we know that. Gets in as interstitial fluid. Doesn't get recovered completely, and instead gets picked up by the lymph vessels, and the lymphatic vessels transport this through various filtering structures that I would call filtering, but they're really part of the lymphatic system, such as the lymph node. And eventually the lymphatic trunk delivers the lymph back into a vein, and it joins and becomes part of the plasma. Okay? Now, why is that so important? Because we're going to be talking about how the lymphoid tissues basically play a key role in stopping the pathogens after they breach the first line of defenses. Let's talk about the difference between primary and secondary lymphoid tissues. Primary, these include the thymus, the bone marrow, and they're necessary for the production and maturation of leukocytes and other formed elements in the blood, such as the B cells and the T cells. B cells, to help you to remember, those are pretty much going through some maturation in the bone marrow. T cells get an activation and maturation that occurs in the thymus. Now, in secondary lymphoid tissues, these will filter lymph and sample the surrounding body sites for antigens. Now, when we talk about sampling the surrounding body sites, that we've particularly seen with tonsils, we call them also adenoids. You would see this with spleen. You would see this with some of the lymphoid tissues, the Peyer's patches, things like that. The filtering is particularly prominent with the lymph nodes. Now, we have a particular arrangement called the MALT. That's the mucosa-associated lymphoid tissue. This is a diffuse system of lymphoid tissues located in the mucosal linings and body entryways. These include, of course, the tonsils, the appendix, the Peyer's patches. These tissues play a key role in detecting and fighting harmful microbes. And you can see in this diagram here the primary tissues, lymphoid tissues, which are in yellow, which include, of course, bone marrow. And by the way, it's not just in just one bone. That's wherever you have red and, as the backup, the yellow bone marrow, and also the thymus. The thymus, remember, as we get older, will begin to shrink, atrophy, until it's nothing much more than sort of like gristle. It's mostly like connective tissue and some fatty tissue, etc., but it really doesn't function as much anymore as the thymus as we get older, 40s, 50s, 60s, 70s. The secondary lymphoid tissues include, of course, the adenoids, the tonsils, the lymph nodes, spleen, the Peyer's patches, the appendix, and of course you can see the distribution of the lymph nodes also. Now, leukocytes. Leukocytes are essential in all immune responses. They're divided into two major groups, granulocytes and agranulocytes. Usually what happens is that you add a stain, and this stain will tell you whether you have granules present. And these granules will exist in neutrophils, eosinophils, basophils, and mast cells. These granules play certain roles, which we'll get into in a few minutes. And by the way, a lot of these cells don't have a typical round, spherical-looking structure called a nucleus. Instead, it may be bent, somewhat kidney-shaped, or actually multi-lobed. We'll get into this in a minute. Agranulocytes, these are cells without granules, and they're as viewed by cell stains, and these include the monocytes, dendritic cells, and the lymphocytes. This is where we get into using a very sharp technique called differential white blood cell count. This is a really straightforward, it's also called the WBC differential. It's a really straightforward test to make a determination if someone has, let's say, bacterial infection, parasitic infection, etc. You basically look at a smear and count the different types of white blood cells present. That can help you to determine the diagnosis. Now, leukocytosis is an increase in leukocytes. They are different from the normal range. This is really the second line of immune defense that provides time for the third line of defense to become activated. So here's what I mean. Now, if you take a look here at the granulocytes, you see the neutrophils. No, those are not separate. They're actually connected together. But this is what you get. It's also referred to as polymorphic neutrophils, PMNs. And this is where they're multi-lobed nucleus, but they're highly phagocytic, and they fight many invaders, including bacteria and viruses. Eosinophils are very strange in the sense that, yes, you'll get this nucleus, but you'll also get kind of a reddish orange staining granules. The stain is able to determine whether the structures are acidic or bacillic. And if they're acidic, if I'm not mistaken correctly, they're going to have more, they're going to pick up these eosin, which is a cell stain. Eosinophils are basically very, very low in number normally. They're moderately phagocytotic, and they attack allergens and parasites. If you have a high eosin count, that may suggest that you have a parasitic worm, for example. Basophils, these also will attack allergens and parasites, but they're going to be having dark purple granules, okay? And they'll have a bilobe, meaning it's kind of like a dumbbell shape, you know. And then, of course, you got mast cells, which they have a nice normal circular nucleus, but they're going to be found a lot of times in tissues themselves. They are moderately phagocytotic, and they attack bacteria, allergens, and parasites. Now, agranulocytes. Notice the monocyte. It's kind of got like a U-shaped structure. It's a horseshoe-shaped nucleus. Also, they're highly phagocytotic. And a lot of times they will mature into macrophages. Now, macrophages can be fixed, meaning that they're permanently stationed in a tissue, such as liver, Kupffer cells, or they're going to be in spleen, for example. But others are wandering around. They flow around in the blood until they get called up to fight against things like infections in the tissue. Dendritic cells have a ruffled membrane. It's kind of like if you take a tablecloth and you get lots of ripples and stuff. You're trying to lay it nice and flat. But the thing is, they have long cytoplasmic extensions. They're highly phagocytic, and they activate adaptive immune responses. These are the guys that take certain antigens, hand them over to teach the B cells and the T cells, hey, you see this? This is where you have an invader, an antigen. The lymphocytes, these we're going to get into a little bit now and more in Chapter 12, because in Chapter 12 we're going to be talking more about adaptive immunity. Lymphocytes can be in several classes, either NK cells, meaning natural killer cells. These are innate immunity against viruses, parasites, bacteria, tumor cells. B and T cells are part of the adaptive immunity. They all have round cells, not a lot of cytoplasm, but huge nucleus, okay? And here you see examples of the leukocytes and some of their responses. If you have leukocytosis of various types, you can see what happens. If you have huge amounts of monocytes, that may be indicating chronic infections or inflammation. Large numbers of basophils. Usually that only occurs with certain rare blood cancers. Eosinophilia, though, lots of eosinophils. That's usually either allergy, asthma, or parasitic infection. If you have an acute bacterial infection, maybe sudden, very quick onset, you're going to see the skyrocketing number of neutrophils. Okay? So let's continue with second-line defenses. I've talked about the granulocytes, the neutrophils, eosinophils, basophils, mast cells. Phagocytosis. Remember that this is basically where the cell kind of just engulfs the antigen or, for example, the bacteria or whatever. All of these types of cells, whether they're agranulocytes or granulocytes, will exhibit this type of behavior. Neutrophils are present in the greatest number for the granulocytes. They are the first leukocytes recruited upon a detection of an infection. They will also release antimicrobial peptides, enzymes from their granules. They will also stimulate inflammation. When one has neutropenia, this is a lower white cell count. It's triggered by some types of viral infection. Eosinophils, I've pretty much given it to you before. You have a high number of eosinophils, you've got parasitic infection. A lot of times that will be parasitic worms, by the way. The granules will contain various enzymes, antimicrobial toxins. Basophils, double-lobed nucleus, loaded with defense molecules and histamine. Hence, this stimulates inflammation and elevated. When you have basophils, it's usually with very rare types of blood cancers. Now, mast cells, keep in mind, they're located in the tissues. These are the cells that release a lot of histamine. So this is where you're going to come in. You say, ah, man, my allergies are driving me crazy, and so on and so forth. And so you go out and you get Benadryl or some other type of antihistamine. Because basically, when they release the histamine, it's going to be a response for tissue inflammation. Mast cells can also help trigger adaptive immune responses. Again, we'll get back to that soon enough. They are phagocytotic. They release diverse enzymes and AMP. Here you see some of the situations. Here you've got this neutrophil, its segmented nucleus, or what they call the band, which is kind of this big lung. Here you see some of these are in glunky. The rest of this is all red blood cells. Here you have an example of a cell phagocytizing, basically gobbling up a bunch of smaller bacteria cells. This will ruffle this membrane outward to kind of encapsulate it and bring it inside where it can be destroyed by digestive enzymes from the lysosomes. Now, when you have agranulocytes associated with innate immunity, remember that there's some of these guys that will also play a role later on in adaptive immunity. What we're talking about here are monocytes, which happen to be the macrophage precursors, dendritic cells, certain lymphocytes. Monocytes are the largest agranulocyte. The numbers increase due to chronic infections, inflammation, autoimmune disorders, and certain cancers. In other words, if you have this persistent infection, you should see lots and lots of monocytes. They will migrate out of the blood into tissues and begin the battle. And as they do, they will mature into macrophages. They're highly phagocytic, and they have a large range of pathogens. They'll go after lots of different types of pathogens, staph, strep, the whole 9 yards. Macrophage types. Keep in mind, I mentioned already earlier, there's fixed, there's wandering. The fixed hang in specific tissues. Another example besides the Kupffer cells in the liver is the alveolar dust cells that you find in the lungs. They're right down in the alveoli of the lungs and keep it nice and sterile. Now, wandering ones will wander throughout tissues. Dendritic cells, as I mentioned, they're abundant in body areas in contact with the environment, the body gastrointestinal tract, or the nose, or the mouth. They go after a wide range of antigens, and they're found in most of the body tissues. They prevent the immune system from attacking its own tissue, or they also help prevent overreaction to non-threatening substances. Okay. Lymphocytes. Well, okay. NK cells, B cells, T cells. I just want to focus in on natural killer cells right now. We'll get more into chapter 12 later. Natural killers are abundant in the liver. They got into this interest because they are very effective in fighting off tumor cells. They will provide an innate immune protection for a wide variety of viruses, bacteria, parasites, and tumor cells. And here you see them duking it out. This is, as we continue with the second line of defenses, we're now going to go into the molecular. This is where we talk about molecules that do the following. They recruit immune cells to the antigen site. They restrict pathogen growth. They may generate fever. They may induce inflammation. Now, there's a wide variety of defense molecules that mediate the innate immune responses. We'll get into some of them. I just want to give you a good solid understanding of some of these applications, because now they have moved from just being scientific curiosities and areas of wonder and research for immunologists, but now they've become diagnostics and in some cases actually therapeutics. Part of this is because of the incredible work done by biotechnology to isolate the genes for these cytokines and produce them in large quantities. What are cytokines? These are signaling proteins that help cells communicate with each other. They will initiate and coordinate immune actions. So, if we look at these here, we have cytokines, which can stimulate inflammation, generate fever, recruit leukocytes to fight infection, stimulate tissue and blood vessel repair. They will also promote leukocyte and lymphatic tissue development. They have also, one class of them, the interferons, have antiviral effects. In other words, what they do is they will actually stop viruses that may be inside of cells replicating, or they will interfere with the effective functions of a virus, etc. They're also, some of these cytokines are involved with immune system regulation or activation. Now, several of the other types of molecular defense molecules we're going to talk about are the iron binding proteins. Iron binding limit the ability of free iron to reduce basically bacterial growth. Bacteria really need iron as part of their enzymes and a variety of other biochemical applications to proliferate. You sequester the iron, you starve out the iron, bacteria can't grow as much. Next, complement proteins. These will stimulate inflammation. They will also tag targets for elimination. This is where we get into the principle of opsonization. And they will actually directly kill targeted cells. This is where they initiate cytolysis, the breaking up of the cell. Now, examples of cytokines, we're going to focus on that first. We have chemokines, interleukins, and that's the IL-1 family, the IL-2, and then interferons, and then, of course, tumor necrosis factors, TNF. Now, keep in mind that you need to get the big picture of all of this. Some of these, chemokines alone, there's 40 different types. And some of them, what they really do is they're involved with recruiting white blood cells to the areas of injury or infection. They're the flag that says, come here, we need help here. All hands on deck. Some of them are also playing a role in wound healing, blood vessel formation or repair, lymphoid tissue development, or the activation of innate and adaptive immune responses. Interleukins and interferons we're starting to see in the marketplace as therapeutics. IL-1 family regulates inflammation, stimulates innate and adaptive immune responses, and helps to generate fever. So you have to keep in mind something. Someone that's going under some interleukin therapy may have some of these other effects that someone would say, well, that's probably adverse effects, but it actually is part and parcel of what has been generated as a result of this interleukin. In which, yes, you're going to regulate the inflammation and you're going to stimulate the attack against the infection, but as part of it, you're going to get fever. The IL-2 family influences T cell development, and it plays several roles in generating the immune system self-tolerance. In other words, preventing you from having an immune reaction against skin tissue, muscle tissue, basically connective tissue, cartilage. Interferons, there are three major types: alpha, beta, gamma. Alpha and beta, both are made by virus-infected cells. They signal their neighbors to basically mount antiviral defenses, because basically what they're doing is signaling the neighboring cells, which would be eventually infected by the same virus after it finishes taking over that individual cell and replicating lots of copies, is stop the spread of the virus in the surrounding tissues. They will also stimulate innate and adaptive immune responses to viruses, bacteria, parasites. Now, keep in mind, again, you can have some side effects if you call them side effects. It is important to recognize the importance of fever, and we'll talk a little bit about that in a little while. Gamma is made mainly by the natural killer cells and certain T cells. What it does is it activates macrophages. It stimulates the innate and adaptive immune responses, again, to viruses, bacteria, parasites. What does tumor necrosis factor do? Oh, there was a lot of research and controversy in the 80s over this and going into the 90s, because they said, what is this stuff, TNF? And they had actually called it cachexin at a point, because what would happen is individuals would start losing weight, etc. It's made mainly by macrophages, induces inflammation, kills tumor cells, which is great, and also induce fever, and suppress, in some cases, appetite. As I said to you before, chemokines, there's a lot of them. The basic points are, these are signaling proteins. They attract white blood cells to, let's say, the site of infection. They'll trigger chemotaxis, in other words, basically cell movements in response to a chemical stimulus. If the stimulus is positive, the cells move toward the stimulus, to the chemical. Interleukins, they activate adaptive and innate responses. They also will stimulate new blood cells and platelets. Interferons, they are signaling molecules. They will issue an alarm when pathogens or tumor cells have been detected. They can also interfere with viral replication in infected cells. So I've talked about alpha and beta and gamma there, but I wanted to just make sure that you're clear on these points. TNF, tumor necrosis factor. This is basically made by mostly the macrophages. Now, again, it plus a lot of other cytokines was starting to be much greater produced in the 1980s as a result of biotechnology. You take the gene out, you put it into some other cell, produces a lot of this stuff, then you start studying it. Tumor necrosis factor alpha was targeted by inhibitors, and these were used to treat immune disorders. And what I mean by immune disorders is this: when you're having your immune system attack your own tissue. Diseases like inflammatory bowel disease, IBD, and rheumatoid arthritis were two of them. Now, here we see this in a diagram of what interferon can do. And I just want you to just review this as we continue to move on. The cell is infected by the virus. That's what is going to cause the cell to release this, if you want to call it the flare, to the rest of its neighbors, that it's been infected by a virus. And that flare is in the form of interferon. Interferon will activate leukocytes. It may trigger apoptosis. Now, if you're not familiar with that term, that's programmed cell destruction. What it may do is it may activate around the cells from this virally infected cell self-destruction. Okay, in other words, the suicide of the cell, and it'll basically bubble off into blobs of cellular material, but basically the cells will die. All right. Now let's go into iron-binding proteins. Now these are proteins that sequester iron. When I say sequester, kind of hold it tightly. Okay. Only for me. That type of mentality. So they basically will hold iron for the host use and prevent pathogen access to the iron. These variety of proteins exist. They include lactoferrin and transferrin. Now, the interesting thing is there is a type of molecules that pathogens use called siderophores. These sequester the iron from host cells or tissues because the bacteria or the pathogen needs that iron. So siderophores allow iron transport across pathogen cell membranes. Now here's the question. Ready? How would a patient with hemochromatosis, which is an iron overloading disorder, have difficulty with pathogen infections? I just want to give you a second to think about this. Now, hemochromatosis is a situation where the individual cannot get rid of excess iron. It continues to build on it. So as we know that how red blood cells break down, you break down hemoglobin, you take out the heme structure, you take out the iron, you've got the rest of the porphyrin structure, which is part of the heme. You get rid of the proteins, part of the heme, and everything is taken around, but the iron never gets excreted out. So it builds up in tissues. It can have deleterious effects on the liver and a variety of other organs, but here's the other problem. You can't keep it totally sequestered against pathogens, and so now the individual has a higher risk of pathogens, infections, if they have high levels of iron in their blood and in their tissues. Okay, so a patient with hemochromatosis has a higher risk of infections. Okay, that's just to give you something to think about. So here you have this entire pathway of host iron binding protein, and it breaks it all down. The pathogen, though, uses certain siderophores to bring it inside, and it will allow itself to do this. Now, by the way, there are other metal ions that pathogens may sometimes use instead of iron. One of them is manganese. Okay. Now, the next area we're going to deal with is complement. Now, complement is a whole cascade, similar to what you learned in anatomy and physiology when it came to the clotting cascade. Okay. Basically, these cascades, one protein activates another one that's inactive, and then activates another one that's inactive, and then activate another one. And so you've got what they call C1, C2, C3, C4, 5, 6, and it goes on and on. There's over 30 proteins activated in this cascade fashion to protect against infectious agents. What activates them? There's a couple of different routes. Macrophages, neutrophils, and certain blood clotting proteins will activate them. But what do they do? Oh, this is great. One is called opsonization. The complement proteins tag the cell for phagocytosis. It's basically putting a flag on let's say the bacteria, just to give you an analogy, and says, kill this. Another is cytolysis. The complement proteins form this membrane attack complex called MAC. And basically, if you would take pieces of it, put it into the cell membrane, you create this hole. Well, you know what membranes are supposed to do. They're supposed to be semi-permeable membranes. They control what goes in and what goes out. But now when you've got this hole, it goes right through, right into the cytoplasm. Stuff can go in, stuff can go out, no control, cell blows apart, cell lysis. Inflammation. Complement proteins will recruit leukocytes and releasing signals that cause inflammation. Okay? Now, there are 1, 2, 3 complement cascade pathways. First one, classical pathway, activated when the antibodies bind to a pathogen. You'll see cells, they'll be attached with a bunch of antibodies. We'll deal more with antibodies, for example, in chapter 12. That's with the adaptive immune system. Another alternative pathway, and these names were kind of arbitrarily kicked around for a bit, but they work. This is activated by directly interacting with the pathogen. For example, the complement binds on the pathogen surface. So you get one of them that binds and it starts the cascade. The third way is called lectin pathway. This is activated when a mannose lectin, which happens to be a blood protein, binds to certain sugars on the pathogen surface. So if the pathogen has basically mannose, which is a type of sugar, on its outer surface, okay, and the lectin binds onto it, it's like, gotcha! And suddenly the antibodies bind, and the complement cascades, you don't even have to have the antibody bind in this case, but as soon as that lectin has bound, suddenly, ta-da, we've got this cascade going. 30 proteins all play a role, and basically you just go to town and destroy the pathogen. Now, how do you shut it down? How do you shut down the pathway? Well, complement proteins are very, very unstable, and they break down if they're not bound to other complement proteins. Okay, so if you go back into your book and you see the pathway of lots and lots of proteins, I believe 337 is page 337 as an example. If these are just floating around there and they're not able to activate other complement proteins, they break down. There are several regulators of complement activation. They're called RCAs, which are proteins made by the body that basically shut down complement cascades after the threat passes. So you've got two means. One, if you still keep making complement proteins, but there's nobody there to destroy, you'll start seeing the cascade fall apart. Two, if you have the RCAs generated to kind of quell the activity, that'll shut down the pathway also. As you can see here, this is the diagram that I was telling you about that you will find on, it was on page 337. But here you see the different activation pathways and the outcomes. You have C3 activating C3, breaking it down into C3A and C3B, and that binds and cleaves C5 and C5B and C5A, and they go on and on. You've got C6, C7, C8, 9. All of this is going on. It's a cascade. Okay, one's got to attack another, it's got to attack another, it's got to attack another. And if they don't, it's all over. Wow, things are moving along here. Let's start talking about inflammation and fever. This is part of the innate immunity too. Remember, these are all generalized, I'll put it that way, Generalized strategies to fight against an infection, to fight against a pathogen. Doesn't mean they're always going to be successful, but it's part of how the body basically fights against infection, and we've got to have an understanding of this. Inflammation and fever are key protective innate immune responses. Combined action of the cellular and the molecular second-line defenses trigger inflammation and sometimes fever. Now, inflammation has gotten a bad rap. Sometimes it really can cause a lot of damage, but other cases, it is very important in defense. But it can occur in damaged tissues. The three main goals of inflammation: recruit immune defenses to an injured tissue, limit spread of the infectious agent, deliver oxygen, nutrients, and chemical factors essential for tissue recovery. Keep that in mind. So, what are the cardinal signs of inflammation? Redness, pain, localized heat. Now look, localized heat is not fever, okay? But it's kind of like they all kind of go together, because if you're going to have redness and pain, you're going to have the redness, you're going to have an increase in blood flow into the area, so that localized area will have obviously increased amount of heat, okay, because of the blood flow that's going into that area. Also, the blood flow will probably mean that there's going to be more transport of fluid from the blood into the tissues, which will account for swelling, okay? We may have, and this is referred to as the fifth sign. It's not always there, but it's called loss of function. And what I mean by that is, oh, wow, I ended up cutting my finger and now it's kind of swollen. I can't move it around as much. That would be loss of function, or reduction of function. There are three phases of the inflammation process: vascular changes, leukocyte recruitment, and resolution. Okay, and you can see that. Let's take a look at that little puncture there. You have, could have been a thorn, could have been a splinter, whatever. Gets into the skin, goes from the epidermis to the dermis. You now have tissue damage from the trauma and or infectious agents. You have a blood vessel nearby. Let's start talking about what goes on here. First, with vascular changes. First off, you're going to have vasodilation. Blood vessels will dilate. They will expand their diameter to allow more blood flow into the injured site. As a result, also, you're going to have increased vessel permeability. This is the increase of the permeability, the passage of materials through the vessel walls. So that's going to allow more fluid, which is what we call exudate, to enter and enhance blood clotting. Okay? You've got to stop the bleeding, as the saying goes. Now, there's a presence of a molecule called histamine, which is a vasoactive molecule. It acts to enhance vasodilation. Does that mean we can use antihistamines to reduce it? Yes, but do you really want that? See, one of the things you're going to find is there's a concept known as Darwinian medicine. And they will ask the question, what is the fitness, or what is the strategy? Why do we have this occurring? Come to find out, some inflammation and some tissue issues like fever are part of what helps us to defend against infections, defend against injury, etc. So just because you've got this puncture wound and you've got some inflammation there, do you really want to use antihistamines when really what you're doing is increasing your vasodilation? You're moving more blood over to the area, you're moving more nutrients, and we're going to continue to keep going through this in a minute. Probably you don't want to use antihistamines at that moment. Later, perhaps. But we also have the presence of kinins. These are blood plasma proteins. They enhance clotting. They activate pain receptors. Ouch! They induce vascular changes. The vascular changes are brought upon us by eicosanoids. These include a class of eicosanoids known as prostaglandins. Prostaglandins are arachidonic acid derivatives. Arachidonic acid is a structure that's somewhat like a modified fatty acid. Now, what eicosanoids do is they induce the pain receptors. Again, why do I want that? Because pain is a good purpose of telling us there's tissue damage here. In the meantime, also what they do is they will enhance vascular changes. Now, again, NSAIDs, non-steroidal anti-inflammatory drugs, can block the synthesis of these compounds. But sometimes the question is, do you really want to use them? The initial cells playing a role in all of this, by the way, are mast cells. And remember, mast cells will release histamine, which leads to vasodilation, which is going to stimulate blood to enter the local area, producing the local redness and the heat. Again, this is local heat, not fever. Okay, so you can see where these situations occur. And you want to basically not only seal off and prevent blood loss, but what you want to do is you want to send out protection in the form of complement proteins and start attracting white blood cells to start dealing with the infection that probably has occurred as a result of this puncture wound. Okay, so vasoactive molecules and other molecules are going to play a role in vasodilation. The vessel becomes also more permeable, so you have fluid being delivered, the exudate, and eventually what you're going to start seeing is pulling in the heavy hitters of immediate defense, and those will be the macrophages, etc. Let's talk about that. Our leukocyte recruitment phase, that's next. This is where we're going to fire off chemoattractants. These are chemicals that are going to include such as cytokines and other signaling molecules. What they're going to do is they're going to flag leukocytes. Hey, we need help over here. And basically, they're going to attract these leukocytes to the injured tissue site. Now, what happens is this. Normally, leukocytes are flowing around in the blood vessel. So how do they get out? First, what they have to do is upon exposure to these chemicals, they're going to slow down in their transport through the blood vessel, do what is called slow, roll, and adhere to it. This is margination. Basically, they start attaching to some of the wall of the blood vessel. Now, this can be also capillary, guys, so be aware of this. And they start attaching, rolling, adhering, and they start eventually squeezing through the gaps that have now been enhanced in the blood vessel wall. And that's diapedesis, this changing in shape to squeeze through the blood vessel wall and get into the tissues. The key players of this is going to be neutrophils, monocytes, macrophages, the immediate innate cells that are going to come in there and start gobbling up the bacteria or whatever else is causing the infection. And here you have the leukocyte recruitment. Chemoattractants such as cytokines, etc., are going to be released by the local tissues. And you're going to have also some mast cells that are going to attract leukocytes. The leukocytes are also going to attract even more of their, shall we say, brethren, if you wanted to call it that, but basically similar cells. And that's going to have more neutrophils, monocytes, and macrophages. Margination, attaching, slowing, rolling, and then squeezing through, and that squeezing through is the diapedesis. They have to go to the site. They have to move in, and they have to start attacking and destroying the bacteria. A lot of this stuff you and I are barely aware of because it's happening all automatically. It's an innate response. Finally, the resolution phase. We've activated the leukocytes in the tissue. Well, eventually the job gets done. And so basically their numbers start decreasing in that tissue area. The surrounding blood vessels are going to relax back to normal state. In other words, vessel permeability will resume to normal, vasodilation reverses. You have the swelling will decrease as the exudate, the excess fluid, is being removed by the lymphatic system. Great. Late in the phase, we start talking about wound healing again. Now, if you remember in Anatomy and Physiology 1, we talked about this when we talked about skin and wound recovery, wound injury, okay? So what do you have? Blood clot dissolves, new blood vessels are formed. This is angiogenesis. The leukocytes, now in excess, undergo apoptosis, programmed cell death. Pus, as a result, may start to form. This is going to form from dead tissue. This is going to form from leukocytes. This is going to form from fluid exudate. It may also, several of the factors may contribute to it, such as some of the dead bacteria cells. If the bacteria cells release a toxin, they may have killed some of the macrophages or leukocytes. No problem. That's all going to be part of pus. And that will eventually also, unless it gets to be excessive, will be absorbed by some of the macrophages and leukocytes, etc. One thing to keep in mind, if there's way too much of it, it may get to be painful, and hence that's where doctors come in and they do a lancing and remove some of it. But a lot of times you will get a little bit of this, and it may not be significant and may eventually be reabsorbed by living tissue. Now, depending on the severity of the injury, the location, the extent of the damage, tissue replacement may be not normal tissue, but scar tissue. This is where we get into forming a scar, fibrosis. But the key point with the resolution phase is that the cells involved in this process include neutrophils and macrophages. As you can see here, we may have had some pus that is leaked up to the surface, the return of the exudate to the lymphatic cells, the lymphocytes, and the neutrophils, and the macrophages. These guys are all going to either die or move off, okay? Pus is really dead cells with a fluid exudate, okay? Swelling is decreased, inflammation falls off, it's reduced. Blood vessel repair begins, and eventually the tissue begins to recover and heal. But if you notice that this was a cut, and you have the edges of the cut too far away, what will then fill into some of this area may be more fibrosis than the actual recovered tissue itself, depending. That's why we have things like stitching and stuff like that. Okay, what about chronic inflammation? When the inflammation process goes on too long, we have problems. Inflammation shouldn't be going on for months and months and months. Extended periods of inflammation result in the following: further tissue damage. This may promote arteriosclerosis, the narrowing of blood arteries. You may actually have the development of various cancers or progressive neurodegenerative disorders such as multiple sclerosis or Alzheimer's disease, etc. Now, mind you, this is not, I prick my finger and, in 2 days I'm going to have Alzheimer's. This is more something that would be an injury that has sustained inflammation. I'll give you an example. I know the case of an individual. When they had to remove her gallbladder, she had a problem with gallbladder for many, many years. So there was a lot of inflammation there. As a result, you had a lot of scar tissue form around it, and it made it very difficult when the doctors were trying to extract the gallbladder, because they had to really cut through so much of the fibrosis around the gallbladder. Okay? Now, no, I'm not going to sing the song Fever. Sorry. And what is fever? Fever is a systemic, meaning throughout the whole body, innate immune response. Okay? You want to talk about COVID-19? What's one of the signs that they check at airports and every other place now? Do you have a fever? And they monitor you. They have the little devices that check, as opposed to sticking it in the mouth. Now they do the forehead and adjust it and so on. Fever is an abnormally high systemic body temperature. Keep in mind that the thermostat for the body is really contained in the hypothalamus. Okay, now what's going on here? Well, we have these materials called pyrogens. These are fever-inducing agents. They include things like bacterial toxins, endotoxin, etc. Now, what they're going to do is they're going to trigger the release of cytokines, particularly interleukin-1, tumor necrosis factor, and interferon alpha. Now, these cytokines are going to act in the hypothalamus to raise the body temperature. So the body temperature reset goes like this. You change the body temperature. The body temperature now gets elevated. There's importance to this. You have hormone level changes that lead to shivering because the person is starting to feel colder at the lower temperature. You're going to have an increase in the metabolism. You're going to have also a constriction of skin blood vessels. This is basically a strategy to conserve body heat. Okay? Now, why is this going on? Because fever is very, very useful in the defense against infection. Now, I encourage you to review the table for fever terms. How do you know when fevers break? You know, if you go back to the old 40s and 50s, maybe even the 1930 movies, they'll have the doctor there. Yes, he made house calls. And he's talking, and you got this little kid with a terrible fever. And when do the fevers break? When the person starts sweating. When the fever breaks, you're resetting the thermostat. In other words, the prostaglandin levels will begin to fall. And so the hypothalamus will reset it back to the normal body temperature, 98.6, okay? And to cool off the body, which has been at, let's say, hypothetically, let's say 101 or 102, you're going to get sweating. It's a thermoregulatory mechanism to drop the temperature. So whenever the individual starts sweating, their fever is breaking. But you got to keep in mind the importance of fever. It acts to inhibit pathogen growth. How does that happen? Well, if you remember from even going back to AP1, we talk about how proteins can be denatured and how denaturing can be irreversible by raising the temperature. Basically, when you have fever, it will affect the proteins and the enzyme functions for the pathogens. It can denature those proteins in some cases. Also, fever will enhance the antiviral effects of interferon. It will also increase phagocyte efficiency, enhance leukocyte production, and it will also promote tissue repair. Now, there's several different types of fever. Low-grade fever, I'm going to keep you on the Fahrenheit terminology, okay? So instead of saying everything in Celsius, I'll keep the Fahrenheit, but Celsius you can see is 37.5, 38.3. Basically, if we had normal temperature, we would be at 37 degrees Celsius instead now, which is 98.6 Fahrenheit. And what we have here for a low grade is 99.5 to 101. If you have a serious high fever, that's where you're going at about 40.5 Celsius or 105 F. That's life-threatening. People get nervous when you hit 104. The reason why is that once you start getting into 104 and above, you face the possibility of having your own cell enzymes and proteins begin to denature. Now, this can be because there's just the body is having repeated amounts of prostaglandins and other cytokines signaling going, you've got to go higher, you got to go higher. And that's when sometimes you literally have to put the individual in cold water or bring the fever down. Sometimes it'll be, rubbing alcohol to cool the body down. The main point is that you face the possibility of also seizures at this high temperature. A fatal fever is above 43 Celsius or 109.4. Now, we know about nonsteroidal anti-inflammatory substances, aspirin, acetaminophen, ibuprofen. They block prostaglandin synthesis. Here's a poor little girl. She's got a fever, and she's going to feel terrible. Okay? And so what's going to happen is the cell membrane phospholipids basically are set over and converted to arachidonic acid, which then will be sent over to echinocenoids, particularly prostaglandins and thromboxanes. And that is going to help shift the temperature. Okay? When those levels start falling off, that's when you're going to have the fever dropping. That's why we have an appreciation for things like ibuprofen, aspirin, and stuff like that. Now, the one thing is, here's where we get back to Darwinian medicine. The Darwinian medicine people would say, look, what is the fitness or survivability advantage of fever? Well, we come to see that it is important in the mechanism of defending the individual against infections and to fight the infection. The problem is if you spike it too high, it can be fatal. With a lot of the medicine we have today, you can keep it modulated and keep the temperature with some aspects of the fever to help the individual recover, but this depends on what the infection is, etc. I hope that is helpful to all of you. Oh, and one other thing is that one has to keep in mind that individuals can be, quote, allergic to aspirin, allergic to certain types of NSAIDs, and also if the fever is too long, it may be much more complex and require more immediate action by medical doctors, staff, etc. Here is the classification of fevers. Now, I'm not going to have you memorize all of them. I do want you to be aware that some of them differ, basically because of the rhythmicity or the intensity of them. Some of them are associated with particular types of infectious agents. So the FUO, the fever of undetermined origin, fever of at least 101, persists more than 3 weeks, isn't linked to any particular cause. If you don't have something and you can't really lay it down, it's usually due to infections or neoplasms. In other words, the person has some type of cancer. The intermittent fever, the body elevates but then falls to normal at some point in the day. Well, that could be something more influenza-like. Pell-Epstein fever lasts 3 to 10 days, followed by non-fever state of similar length. Characteristic of Hodgkin's disease, certain other lymphomas. Relapsing fever, this is usually recurrent episodes spaced by days or weeks. Characteristic of certain tick-transmitted bacteria such as Borrelia. Okay. Remittent fever, elevated body temperature that fluctuates but doesn't reach normal in the course of the fluctuations. Sustained fever, consistently elevated body temperature with limited fluctuation, okay, during a 24-hour period. Then you have tertian and quaternion, and these really are basically fevers that occur in pulses. And this is common with certain types of malaria, in part because what happens in these cases is that when the plasmodium breaks, they all kind of break at a particular time from the red blood cells, release their toxins and other materials into the body. So their lifespan goes within about a 3-day period for Plasmodium vivax, or Plasmodium malariae more 4 days. And so you have these periods where they have spikes and chills and spikes and chills, and then sort of a quiet couple of days. Okay? And so we're done with this chapter. And we're going to go into adaptive immunity in chapter 12. But before I do, I want to remind you to go over the visual summary on page 372, chapter overview on page 346. Now, the summary 372, just to give you a heads up, covers both chapters 11 and 12. Okay, enough said there. The end of the chapter questions are 348, 349. Make sure that you get the Mastering Microbiology homework and quiz done. Review the videos in the Blackboard for the lecture content, and we go into adaptive immunity very shortly. Have a good day.